You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Failure to thrive may seem like one of those non-emergent, specialized pediatric conditions that we just don't have time for. Well, I'm here to remind us all that we are the watchers on the wall. These children can slip through our fingers to disastrous results. Up to 5% of admissions in children under the age of 2 are for failure to thrive. It's not uncommon, but it's commonly missed. What is failure to thrive? The simple definition is poor growth caused by just not getting enough calories or not processing them. Usually this is inadequate intake, but it may include poor absorption, increased urinary or intestinal losses, or poor metabolic utilization. You can see already that the simple definition is not so simple. The traditional paradigm splits us into organic or non-organic causes for failure to thrive. That is, organic things like metabolic disorders, or non-organic, like just not giving the infant enough calories, usually associated with some psychosocial issue. This paradigm is also not so simple. In fact, in the literature, there's a current deliberate push to move away from this strict dichotomy. Let's dive a little deeper into picking up the possibility of failure to thrive, understanding what we should do about it and in what setting, and how to rally the troops to your infant patient's cause. Why even bother? Why not let the pediatrician do this? Chances are the poor pediatrician hasn't seen this child in who knows how long, and if no one intervenes, this child's learning, his development, his health and welfare are at serious risk. Most often, the child will not come to you with the chief complaint of he's not gaining weight, or he's not growing, or he's not developing well. Most often, you'll see a child with a seemingly unrelated complaint, like a simple upper respiratory tract infection or rash or diarrhea. When you ask about pediatrician visits, there's some issue. Oh, we just come here. Or, the doctor's always so busy and he can't see Johnny when he's sick. A bit of a red flag. Although, let's be honest, in today's day and age, it's not all that uncommon. So, you review the child's visit list and see that he uses the ED almost exclusively for regular care. Or, he seems to get a lot sicker than he should for a simple viral infection. Don't expect to see a dirty, unkempt child. Failure to thrive happens in any family unit. Although, inevitably, you will see some pretty disturbing things in your career. Failure to thrive is rarely a dramatic presentation. It's usually subtle. No one feature necessarily makes it, but things just don't add up. The tricky part is that failure to thrive is a longitudinal diagnosis. We need to see problems with weight gain, growth, and development over time. That's not very compatible with episodic emergency department care, even if you personally see this child over and over again in the ED. My point here is that we need to look for it because cases get missed all of the time, and if you're concerned about any one single visit, the child is usually already pretty affected by it. Now, let's not fool ourselves, though. In a busy emergency department, we will likely miss it until we see something objective staring in our face like, why does this 18-month-old weigh 8 kilograms? Not good. Now, you may be thinking, How do I know that's bad off the top of my head? It can be especially difficult in the US where parents weigh children in pounds and we doctors do so in kilograms, or if you're not around children at home, or the numbers are just too hard to keep straight in your head. I personally don't trust myself to do math just in my head. Remember the good old rule of thumb. You know, the count by kilos on one hand, by age on the other hand rule of thumb. On one hand, count out years by odd numbers. The thumb is 1, index is 3, middle is 5, ring is 7, small finger is 9. Then use your other hand to count in kilos. The thumb is 10 kilos, index 15, middle is 20, ring is 25, and small is 30. Now, match them up. The thumb is 1 year and 10 kilos. Index is 3 years and 15 kilos. Middle is 5 years and 20 kilos. Ring is 7 and 25. Small is 9 and 30. You can use this for resuscitation estimates as well, for drug, fluid, and electricity dosing. Of course, children may be chubbier than this, but it's a great way to get ideal body weight, or at least an estimate. For failure to thrive, it's a good rule of thumb to keep running in your background, in your memory. Remember, at 1 year of age, you're 10 kilos. Go up by 5 every other year. Unfortunately, something as objective as weight may be the first sign that something is wrong. That's usually when trouble has been brewing for some time. Let's talk a little bit more about how pediatricians think about failure to thrive and how it's more formally defined. There are all variations on this theme, and at times with all of the growth charts and measurements, it feels like we're trying to think in 4 dimensions. Again, let's just keep it simple and copacetic to what we do. Everyone would agree on this definition. Weight consistently below the 2nd percentile for age and sex. What does that mean? To explain, let's review how we would read a growth chart. 2 popular versions are from the World Health Organization and a separate set of charts from the Centers for Disease Control and Prevention. The main differences are in philosophy and practical use. The WHO chart for young children goes from birth to 24 months. It's meant to set standards for where the child should be at what age. The data used to compile it were based on a large-scale longitudinal study with frequent measurements and special attention made to the first several months of life. The intention behind the WHO's growth chart is to intervene early if there's any issue. Also, by the way, the WHO charts were done to set breastfeeding as the standard, as most babies in that study were predominantly breastfed. The CDC growth charts were not made to establish standards, but to reflect the population. In addition, there was no data collected for the first 3 months of life, so that information was imputed in the CDC growth charts. The official recommendations of the CDC are actually to use the WHO charts for the first 24 months, then use the CDC charts for 2 years and later. The WHO chart goes to 36 months, and in practicality, that's what most people use until the child outgrows it. Also, the WHO only has growth charts up to age 5. So, to recap, use the WHO charts for infants and children birth to 36 months, especially for the first 2 years, and then you can use the CDC growth charts afterwards. They go up to age 19. To keep it even simpler, just use your handy reference, your Harriet Lane, or whatever reference you come into contact with on a regular basis. We're talking broad strokes right now. There are separate growth charts for girls and boys, for length and weight, and for age. For simplicity, let's stick to the chart from birth to 36 months, since that's where we want to pick up the majority of our cases. Make sure that you're using the right chart. Even if it auto-populates for you in your electronic medical record, be sure it pulled in the right info. Find the child's age in months at the top, the y-axis, and then follow that line until you reach his weight on the left, the x-axis. The corresponding curve, of course, that you'll find is his weight percentile. Now, while we're at it, what's a percentile anyway? Think of all the observed measurements of weight, for example, all of the measurements that we take in a population as a normal distribution. Rather than just saying average, below average, above average, we need some finer tuning. So we use more exact statistics, like percentiles. A percentile is a measure that indicates the value below which a given percentage of observations in a group falls. In this context, we plot a weight for age, and the curve it falls on will tell us the percentage of children that weigh that much or less at that age. Now, on our road to becoming clinicians, we took a lot of tests. We think of percentiles differently. When you take a standardized test, you rarely get the actual raw score. You get a converted measurement, a percentile, to tell you how you rank when it comes to the other go-getters who took the test. So, if you were in the 85th percentile, your raw score was somewhere in the top 15%. Another way to look at it is how we look at growth charts, is that your score was as good, if not better, than 85% of the people taking the test. Now, we have to change our test-taking mentality a bit. Higher is not necessarily better when it comes to growth charts. Several things influence our raw score for height and weight. Genetics, the environment, intake. A healthy child at the 10th percentile who cruises along nicely on his little 10th percentile is totally fine. Parents often come in thinking that it's a test. The bigger, the better. When you tell them that their child is in the 50th percentile for height, they want an improvement by the next visit. Remember, we're looking for trends, not absolute numbers. Percentiles are statistics based on the raw number. If you cruise right along the curve, you're doing great. You can cruise along that percentile highway, but there is a danger zone. If a child is consistently below the 2nd percentile, that is, the lowest possible weight for his age, we worry. Again, if he was always cruising along at that 2nd percentile, that is just who he is, and as long as he's otherwise doing well, there is nothing to worry about. If he falls off that percentile and stays off below the 2nd percentile, then there's a major problem with growth and subsequently with development, because no one is or should be that low in weight at that age. Now, that is a pretty dramatic presentation. Remember, we're talking about previously healthy children, not those with special needs or other comorbidities where we expect them to be low in weight or length for their age, but they will also typically follow along their own percentile. We're talking about children for which we have no other known reason why they should be failing. Unfortunately, we see it not too uncommonly. Another variation that's important to be aware of is when the child falls off his growth curve for 2 or more consecutive measurements. So, for example, let's take little Susie. She's 18 months old, and she's 10.2 kilograms. She's at the 50th percentile for weight at her age. She's always been at the 50th percentile for her age since she was born. Her weight right now at 18 months is 10.2 kilograms, which means that she weighs as much as 50% of the population. Cruising right along just fine. Except when she comes to the ED when she's 20 months old, she still weighs 10.2 kilograms. busy ED and it can be missed, but she has fallen off the curve. Any one measurement likely is not a concern, but it needs close follow-up. Susie comes in a month later. Wow, another virus? Or is that early pneumonia? She's now 21 months old and still 10.2 kilograms. Not only has she fallen off the trajectory where she's been her whole life, but now she's at the 25th percentile. Quite a difference. 2 or more measurements that show the child falling off the growth curve. It's problematic and it may need intervention by us. At the very least, it should trigger some deeper history and more thorough physical exam. So to recap, infants and small children should not consistently be below the 2nd percentile over time. They should not be decelerating their growth over 2 or more time periods. Usually this is at least a month or so apart. Which also means, of course, that no infant or young child should ever be consistently losing weight, no matter how trivial. Because, of course, just maintaining weight over too long of a time is very concerning in the infant or small child who is supposed to be growing, developing, and thriving. Now, just to be clear, it's not all about weight. Weight is the first measurement that suffers in failure to thrive. Then, if it's severe, the length. At its most severe, head circumference. By then, it will be blatantly obvious. Our job is to pick these things up before it's an issue, to help parents and families to get their child thriving again. We've talked a little bit about some red flags in the ED that may trigger you to get more history and target your exam regardless of the chief complaint. Maybe you hear about infrequent pediatrician or family medicine visits. Maybe there's an inability to recall the name of the child's doctor. Maybe there's a lack of awareness of immunization status or other clinical milestones. Again, this may be an access issue or an education issue or something else. Regardless, these features can be a proxy for fractured care. To be honest, it's mostly a sense you get when you're speaking with a caregiver. The attitude towards the child's routine care, whether they're following along during the ED visit, whether they're engaging with you, something may not sit well with you. It's an important twinge in your gut to listen to. So you follow through with more questions. What was the birth history? Was the child premature? Was there any evidence of intrauterine growth retardation from some other cause? Maybe there was prenatal exposure to antiepileptics, to alcohol, to smoke. We have to be careful how we ask these questions and do our best to do them in a non-judgmental, very open approach. Is there evidence of a chronic disease or an immunodeficiency? Children with celiac disease, for example, or other absorption disorders are at risk. Obvious past medical history, like congenital heart disease, can explain the imbalance of supply and demand in calories as well. These known comorbidities are often looked after pretty well. We're mostly trying to uncover some previously unknown condition here. Maybe the child is exposed to large amounts of artificial sweeteners. This can lead to problems with poor absorption because of all of that sorbitol that's added. Or maybe he drinks way too much juice and the substantial fructose intake in someone who has an undiagnosed fructose intolerance. That can cause poor absorption of nutrients. Maybe there's a family history of short stature. Short stature itself doesn't equate with failure to thrive, but in a study by Blair et al., infants who had slower weight gain were 8 times more likely to be born to shorter parents than to taller parents. In these cases of suspected failure to thrive, a good review of systems is in order. Now, unfortunately, this may yield a lot of positives, especially in those who don't see their doctor regularly. Maybe you are their one-stop shop. It can be a bit of a Pandora's box, but it still is an important thing to do in the child you suspect may be failing to thrive. If it helps any to try to distinguish the pan-positive review of systems from something more devious, Mash et al. Did a case control study to develop a risk stratification tool to discern medical child abuse in cases of failure to thrive. Now, they set their bar rather high. This isn't trying to pick up the worrywart parent who says yes to every question or someone who wants to make the most of what seems to be a routine ED visit. Mash et al. Found that if there is a report of a problem with 5 or more organ systems, with 5 or more food allergies, without some serious congenital anomaly, these were markers for medical child abuse. If you add to this prediction tool a history of refusing the services of a multidisciplinary feeding team, the sensitivity for medical child abuse in this study was 100% with a 96% specificity. Now, careful here. We're not here to make diagnoses of failure to thrive or even medical child abuse. We're here just to raise concerns and match the patient with the resources he needs to figure out the underlying problem and to recover over time. That said, be on the lookout for weirdo allergies like the Mashin team found, very specific and odd ones that were reported, like being allergic to soap, or beeswax, or paprika, or ranch dressing, or all fruits. Not only are these uncommon, but having multiple allergies to very specific and easily dealt with allergies should raise an eyebrow. And that finally leads us to psychosocial causes of failure to thrive. It's the easiest one for us to jump to, but be careful. We don't really know what goes on at home, the good or the bad. Food insecurity may be a real issue. Family disruption or custody battles may be an issue. When you get a history of lots of social upheaval, instability, or the family just has a whole lot going on, the child is either not offered enough calories, or he's too upset at feeding time to take them in. It sometimes takes a lot of effort to get an infant to feed, and if there isn't that energy that's put into it, however small the increment, that over time can build up to not gaining enough weight. Whatever the case, remember, often the organic causes and the non-organic causes, the psychosocial causes, coexist. The general examination includes the interaction in the parent-child dyad. Usually this is your observing how the mother interacts with the child and how the child will respond. There has been decades of work on this, but I'll try to boil it down to the concepts that we should be aware of. Ideally, mothers and infants show high levels of engagement and reciprocity, meaning they pay attention to each other and needs are met. Parents can be sensitive to the child, but also set limits, or they can be intrusive, controlling, or even apathetic. The child can show signs of complying, as in a controlling type of parent, or even withdrawing from attention in an aloof parent. Certainly, this is all very complex and not a service that we can offer in the ED, but just think a little bit about the numerous interactions that you thought were a little odd. Chances are there was some mismatch in this dyad. All cultural differences aside, there was a straying that you saw from the nurturing, mutually engaging, calm, limit-setting, and comforting nature of a secure dyad. Maybe you saw controlling behaviors or intrusive behaviors, or maybe there was just a sense of apathy or aloofness. Now, you've seen the good, the bad, and the ugly in family relationships. The watchwords to remember when you're observing are empathy, control, and efficiency. Pay attention to your gut, even when one of the two is still not able to use words to communicate what's going on. Of course, height and weight are important. Plot the growth chart if there's any doubt. Look at the child's proportions, his muscle tone, his activity. Is he thriving? Is he a rambunctious toddler, or does he just mostly only exist on his mother's lap? Are his development and motor skills appropriate for his age? Does he just seem a little small and maybe even delayed to you? Any of that should trigger a careful look at his weight and plot it out. All right, you've used your observational skills. You've asked the right questions. You weighed the child, you were worried enough, and you plotted him on the graph. Something just doesn't seem right. You offer admission. By the way, most parents, when you tell them you're worried about the child's being small for his age and you want to admit him, they're relieved. Although they may slowly get used to the child's trajectory or lack thereof, there usually is some nagging truth that's unsettling for them. In most cases, they're happy to have you bring their child in for an evaluation. Now, you may think, he came in for a viral exanthem. Why would I admit him? The reason is this. If you are the one who is worried about failure to thrive and it has not yet been addressed, that itself is a major failure of an outpatient plan. Just think of this. If the pediatrician had seen the child, if he had known the trajectory, and it had all worked out, all referrals were made and intervention started, then that's just fine. Stay the course, do a little bit of counseling, and make sure they have follow-up. But if you're the first one to think of this, to find it, and to mention it to the family, that's a major problem. Now, it's not for us to try to dissect it, to figure out the cause, to get it all wrapped up in a bow, but it is our job to intervene on this very abnormal presentation. We can do a brief screen for obvious chronic infections, for example, trying to diagnose something previously undiagnosed, but honestly, that's all going to be directed by your history and physical. There are no particular lab tests that are routinely recommended. The idea here is admitting the child is important to make sure that we can prove whether he can gain weight or not, and if not, why. Here's the case. Details are changed to protect the innocent. You see another 18-month-old, an 18-month-old boy who is brought in for a rash. It looks like a solitary bug bite. You are underwhelmed. But something didn't seem right. The mother was a bit apathetic and didn't really seem to have a grasp on Johnny's general health. He was in a dirty diaper and a dirty t-shirt. Okay, no crime committed here. He was small. He almost looked like he had temporal wasting. Or was that hydrocephalus? When you ask the mother whether anyone had noticed this, she shrugs her shoulders. Another red flag. The child sits on his mother's lap, not really engaged in anything in particular. He's not really using any language or interacting with anyone. He has good tone because he's sitting up on his own, but Mom's arms are to the sides of the chair. The only contact she had with him was passive. He happened to be sitting on her lap rather than her holding him in her lap. This 18-month-old boy was 8 kilograms. Now, speaking of the chief complaint, the rash, which was a bug bite, he actually had a few different rashes. The bug bite was nothing to be concerned with, but when you examine him, he has various areas of tinea corporis. Again, no one feature is an aha moment. He also has areas of untreated eczema, so 3 rashes, in fact. You have this urge to bridge the gap between the complaint, which was perfunctory, really a non-complaint, to what you were concerned with: failure to thrive. You have no records to refer to, but by definition, this child has been below the second percentile for some time. 8 kilograms in an 18-month-old without an explanation or any previous assessment or intervention is not normal and did not get there overnight. You don't need another measurement a month or so away. So you do some screening labs because none of it really makes any sense, which also bothers you. You do a complete blood count to look for hemoglobin, chemistries for electrolytes. You do a liver panel. In addition to urinalysis, you look for ketones, glucose, or reducing substances. You don't find anything, you weren't surprised, but you still admit. Why? Well, we as a medical establishment can unleash the full force of the empire whenever we want. We can do lots of tests. We can try to figure this out as an outpatient, but we know that's already failed. Since this really boils down to calories, not enough given, not enough taken, or not enough absorbed, we can start with something really low tech, like feeding the child as an inpatient over a series of days. This also gives the inpatient team time to get to know the parents, their needs, and to support them, or to detect any funny business. It also helps to reinforce to the parents what a difference a few extra calories and choices make. We don't need to judge or speculate or theorize or rationalize. We need to take charge and get that child either gaining some weight or figuring out why this isn't happening. In tandem, the admitting team will want to get an HIV test, and based on findings in the history and physical exam, they may do allergy testing or celiac screening or a swallow function study, or maybe more advanced testing like an abdominal ultrasound or MRI for masses or radionuclide scanning for gastric and biliary tract emptying times, and all kinds of camera work like endoscopy, duodenoscopy, colonoscopy, and even small bowel capsule enteroscopy. You know that little small camera that you swallow and you see the inner world of your intestines. My point is that you can do a lot of tests, or at least they can do a lot of tests. We can just be careful, screen for that failing to thrive, and really pass the baton on to the inpatient team. Now, the inpatient team may not come to a final diagnosis, but if the child gains weight as an inpatient, that already is helpful information. He can then be followed carefully as an outpatient. If you meet resistance to admission, just do your best to offer the next best alternative. And this may include speaking with the pediatrician, speaking with a family medicine physician, trying to figure things out with the family, coming up with a team approach. You may have to get more people involved depending on the situation. And if it's an unsavory situation, remember that social workers, police, the Department of Children and Family Services are mostly interested in only one of the two Ds. Dangerous, not dumb. That is, people can make bad decisions for their children. They do it all day long. If you're only mildly concerned about the child, and even though it's not ideal, they may be able to see their pediatrician, then you may just have to let that be. If, however, you see the child has obvious findings of failure to thrive, and that may just be his being underweight for no other reason, and no one seems to really pay much attention to that, you have an obligation to act. If the parents are not at all amenable, then follow your local protocol and get help. You may be the only chance this child gets. It's important to note that not all patients will need admission, but all will need some intervention and follow-up. That is, in mild cases with an intact family and a warm handoff, some contact with the child's doctor, assuming he has one, all of these are prerequisites to the outpatient approach. The clinics, of course, will see this differently because there's something different about presenting to a clinic. There's something different about that child, about that patient, about that situation. If you are the only one who is making the failure to thrive diagnosis, then it's up to you to come up with a sure plan to get the child what he needs. We've just hit the highlights of failure to thrive. It's an ongoing assessment. The approach and management is involved, and it should be tailored to the individual child. These are some tips, in summary, to get it right in the ED. Listen to your gut and pay attention to the weight. Less than the second percentile in weight consistently over time? Failure to thrive. Falling off his growth curve? Possible failure to thrive. Rally the troops. Get this child admitted if you're concerned and are able to, or followed very closely. This is almost never a confrontation, but really a congratulation for noticing, for helping a struggling family. This is an opportunity to make a difference. And all you really did was pay attention. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.